So as I was saying, this seminar will be available in the YouTube channel of MAISE, of the Medical Anthropology Young Scholar Network. But this initiative was initially bring forward for. And so we will continue to have these meetings in the hospital ethnography, but with a kind of a more relaxed pace. So not one meeting every month, but probably we're going to have something like one meeting every 3 months in order to also have a more free discussion. So today it's great to have still 4 presenters that will present their work, and we will be able to discuss with them. And the topic of today's presentations is, so as usual, the series is about the hospital in transit, and the series will be, it is about the possibility to see the hospital as a space, but there's a particular social space that intersect different kind of interests within social sciences, but also in particular within medical anthropology. And we have explored questions like, how does the global role of the hospital has changed? How it has changed also after COVID-19, and which kind of questions or which kind of methods we could use in order to analyze the situation of hospitals as both local and global spaces. And so today we're going to talk about hospital collaborations, and I'm very happy that we have 4 thought-provoking presentations. So I'll just leave the floor to the presenters. And so please, Mariana, if you want to start.
Thank you, Mirko, for the presentation. Could you listen to me well, or?
Yep.
Yes, okay, I will share screen. Is this good? It's fine?
Yep.
Yes? Okay, okay. So I will start. Well, thank you very much for this opportunity to talk with you. My presentation calls healthcare providers and anthropologists in collaboration, a case study from a gynecological and obstetric service of a hospital in Barcelona. So just to quickly present myself, I am Mariana. I am in the 3rd year of my PhD, and I am researching the reproductive care experiences of patients at high risk and or diagnosed with preeclampsia. Okay. So to start, to introduce, in the AFIN research group, we perform a collaborative study between a public hospital in Barcelona and our group of anthropologist researchers to understand the social cultural experience of the patient screened at high risk of preeclampsia, okay, or the diagnosed of preeclampsia. So this study belongs to a transdisciplinary network called RECORS, which means Primary Care Interventions to Prevent Maternal and Child Chronic Diseases of Perinatal and Developmental Origin Network. So we, as anthropologists, carry out the work package 12. We are the only team researching this issue from the social science perspectives. No, the other work packages are from medicine perspective. Okay, so the goal of this research was to learn about patients and professionals' needs and challenges in order to improve the care offered by the hospital regarding the screening and the treatment of preeclampsia. However, as I will discuss today, the actual functioning of this collaboration is not obvious at all once the ethnographers are inserted in the hospital routines. So how to transfer the results to the professionals we work with is one of the most challenging tasks, at the same time that's the most important one, to address for anthropologists in this setting. So the field work consisted in 8 months in an obstetric sector of a public hospital in Barcelona, which included specialized visits for patients with high risk of developing preeclampsia, plus an ultrasound. The delivery room, the obstetric urgencies, the midwife visits, and the prenatal classes for childbirth, and also in-depth interviews with 24 patients and 24 professionals between doctors and midwives. So many times during my fieldwork, I witnessed situations of unequal attention among patients based on race, class, age, culture, and mental health differences. Observing these scenes on a regular basis required of a significant amount of emotional work, which sometimes was hard to handle. My passive role as an observer certainly didn't make things any easier for me. Okay, so I would like to share with you a couple of examples just to explain a little bit. I will read these examples of the field work of my field diary. There is a patient alone. I see that she is a 17 years old girl from the Dominican Republic. The doctor asks her why she has been sent to this high-risk visit. The patient doesn't know. The doctor yells at her when the patient says that she hasn't had any ultrasound yet and she is at 18 weeks of pregnancy. The doctor starts to laugh and says, "This is out of control. I can't work like this." The patient cries because of the rudeness. The doctor asks her other questions, but the patient now remains silent. The intern enters in the middle of this screaming, and the doctor starts to tell her what is going on to the intern, as if the patient were not in the room. The doctor tells the patient that they are going to examine her, even though it may not be as effective as doing it during the first trimester. The doctor, after the exam, tells her, "The baby is badly positioned, but everything is fine. The next ultrasound will show the baby's sex, so you can miss it." Okay, another example. The doctor asks us to leave because the next patient is very complicated. She doesn't want anyone else in the practice. The doctor tells us that the patient is not dealing well with the pregnancy and the fact that the baby is a boy. She reads aloud her medical history file to us, where it says that the patient was raped. She says that she has very strange obsessions, describe her crazy stuff for the interns. They all laugh. The doctor tells us that the patient has done the culture at home and has brought the sample with her. The interns joke about how sorry they feel for her poor husband. The doctor says that it seems she wants a home birth, to which the interns laugh and say how crazy this is. The doctor says she is not going to oppose to that idea because it would free them, the medical staff, from having to deal with her at the hospital. Imagine that lady in the delivery room, the work she would give us. So witnessing these kinds of situation in the field has constantly put me in a trick position where I couldn't talk to the doctors in a fully honest way when casually asked about my impressions of the consultations I was observing. Such attitudes from health professionals often shocked me, and several times I had to rethink the ethnographer's place in the hospital. As I was saying at the beginning, with this collaboration with the hospital, we were expected to help health workers to address their challenges in their everyday work. So we had a major challenge. How could we possibly transfer the results of the field work when they were so obviously uncomfortable? How could we do it without them feeling betrayed by us or defensive about our claims? what was the best format so that this transmission could be done in a sensitive, reflective, and non-judgmental way? And what was it actually possible for this collaboration to have positive impacts for health workers and patients alike? So these were important questions that my research group and me spent long meetings discussing. Finally, we decided that while more detailed, anonymized information could be used by the head of the department to have an overview of the main challenges of the maternal care section, the communication with the rest of the professionals probably need to be more practical in order to be effective. In this way, we first elaborated an institutional report that tackled three main challenges in consultations. The first one was the management of diversity, broadly speaking, in terms of race, age, culture, languages, but also abilities and mental health. The second issue was the difficulties in effectively communicating bad news to patients. And the third one, the challenges in adopting a shared decision-making process. But with an aim to only notify about the problems, along with the report, we invited them to participate in 3 workshops tackling each of these questions. In order not to put them in a position in which we told them about their problems, in these sessions, we provide them some anonymized field examples so they could work with in groups. In these dynamics, they first worked in groups analyzing the situations, and we then had an open debate within different groups seeking to find a common language between medicine and anthropology. We were surprised by the engagement we saw at their end and how many seemed to be enjoying the chance to analyze in detail consultation scenes beyond the medical aspects of it. However, the workshops also brought new challenges that kept us thinking on ways to address the issues that popped up. For example, we shared with a field observation of a patient with obesity who could not sit on the consultation tables because it had armrests. While they pointed out to the lack of inclusive spaces for this patient, the conversation soon moved towards another directions. Some of them considered that obesity was a severe health problem that should be treated, that things should be educated for them because they needed to understand that they have a problem and that it was actually more difficult for them to work with obese pregnant patients. As we can see, we were able to reach some points in common, such as the importance of all women being able to feel comfortable in the practice, but some different conceptions regarding patients and their issues emerged. So now we continue to explore ways of collaborative approaches with the health professionals and thinking that this is an ongoing task that is very necessary. It would be great to share with colleagues other transfer strategies to find a common language between anthropology and medicine. That's it. Thank you very much.
Thank you so much.
Thank you so much.
And
Thank you.
it's extremely interesting. And so I'll just open the floor for questions, for immediate reactions and questions. And then we are going to have, at the end of the session, a more articulated discussion. But now I just want to give the possibility for everyone to ask for curiosities and immediate reactions. Okay, I'll break the ice then. I have a question for you, Mariana. I was wondering, but like the thing that you brought up, and thank you for the very interesting case that you also read. Uh, I was thinking that, like this whole problem of communicating bad news to patients,
Mm,
and within a context in which, as you showed, clinicians are embedded in a milieu in which they still have very xenophobic understanding of the other, and a very kind of judgmental, and so on and so forth. So
mhm.
how do you, I mean, when they ask you to help them how to communicate bad news to patients, how do you deal with that request? How do you, like, have you tried to, I don't know, build courses or safe spaces in which everybody could share their experiences? So how do you deal with that?
With the professionals.
Yeah.
Or So this workshop is specifically about transfer bad news. No, it was very interesting because we are focusing actually in pregnancy loss. That is something that we find a lot of cases like this in the hospital, no, in the field work. And it's a very complicated issue because some doctors are very sensitive of this theme, no, and this subject, and very like care with the patients, but some of them are not. Like mostly like the first trimester, no, of pregnancy loss sometimes. So we start like this work of sensibility, like to tell the doctors how patients tells us that they feel about it. So like this work of like transfer the information, no, like a bridge between patients and doctors. Hmm.
Okay. So basically, yeah, you never put them in the same room, right? So it's just about the information that you gather for patients and to make them into examples to explain clinicians about how they feel.
Yes, yes, exactly. And we proven that like we are asking doctors in these workshops, like what is the most difficult part for them in this role of saying like a bad news, no? Like because we suppose that for them is also like a emotional work that could be hard. So we are like working this kind of stuff as well, no? Like for them having also a support, you know, we are asking them if they can share about it, like in the meetings that they have, but they were telling us that the space of share with information between them, between the doctors, it's more like more about medicine, no, more about technical stuff that is difficult to find this moment to share like emotional things. So we are working, about this. Like we are trying to give a space, no, and a moment in their days, like in their everyday work, to think about it like more. Hmm.
Okay, thank you so much for this. And
Thank you.
is there anyone else that has immediate reactions and questions? Matthew, go ahead.
Hi, thanks for sharing. Yeah, really, really interesting. Question I had was about the section where you described the medical team speaking quite insensitively about a particular person's um,
Hmm.
needs. And I was just thinking, the medical team there are finding a certain presentation quite challenging for them. They're managing it and expressing it in this way. But then you're also now bearing witness to this behavior, which you're finding challenging. So it's almost they're challenged by the patient's behavior. I'd imagine you were probably feeling quite challenged by how they're then reacting to it. So then how were you able to manage that? Where were you gaining support in processing your
Mm.
experience? Um, yeah,
Yes.
that was my question.
Thank you. Thank you for your answer. The only way that I could manage all this is like discussing with my research group, like the AFIN group, because we are all in the field and we are all going through this kind of situation. So it's like, okay, we have a meeting now, a work meeting, but also an emotional meeting because I need to talk about what I saw just yesterday, because it's like a lot to deal with. And in the hospital was, at least for me, was impossible for me to share it with
Yeah.
a doctor or a health professional. I was always very like, okay, everything is fine, because I was very afraid to broke our connection, because
Yeah.
our connection is very recently, like it's a new project, something new. We didn't know each other very well, so I was always like trying to be very discreet, like polite. But with the research group is where we can share all about it and see that is not, I was not the only one who was witnessing this kind of stuff. So we can like improve some consistent consistent idea about what is happening. So this was very important.
That's great. Thank you.
Thank you.
So we might have time for one more question, or we just go ahead towards the second presentation. Okay, yeah. So we will get back to this also to the final discussion. And thank you again, Mariana. And
Thank
so
you.
Paola is next.
Yeah, thanks. I'm going to share my screen. Okay, can you see my presentation? Yes, thank you. Okay. Okay, perfect. Thank you, Mirko. Good evening to everyone. I'm Paula Martone. I'm a second-year PhD candidate in social and cultural anthropology. And as Mariana, I'm also part of a film research group. We belong to the same group, even if we are studying different aspects, different subjects. So today I would like to reflect on doing hospital fieldwork in general. So the title of my presentation is The Hospital as a Social Experimental Setting, Exploring Fieldwork Complexities in a Pediatric and Maternal Hospital in Barcelona. This work has been done together with Dr. Ana Molas, who I don't know if it's connected, but well, I'm doing it by myself. So let me see if I can. Yeah, okay. So to give you some information about my research framework, for my PhD, I'm studying preterm births, the professional, personal, and social implications of preterm births. For those of you who are not familiar with the topic, a preterm birth occurs when a baby is born before 37 weeks of gestation. And these babies still represent for medicine a huge challenge, both related to survival rates and also to quality of life. And for this reason, there exist a few clinical trials in different countries in order to develop what they call an artificial placenta, which is something similar to what you can see here in this image. So what they are trying to create is a device thought to place preterm babies inside and enable that they continue their development outside the maternal uterus. So one of these projects is being done in Barcelona in a hospital, and this is the reason why I'm studying this kind of subject, so preterm births, and also the possible implementation, the implications of this kind of technology. For doing so, I'm conducting an ethnographic research that consists of non-participant observations at the neonatology and gynecology departments in a hospital. And at the same time, I'm also doing semi-structured interviews to parents and healthcare workers as well. So as I said at the beginning, I would like to reflect on some ideas on the feelings and the challenges I encountered when I started fieldwork in such a complex structure as a hospital may represent. So the first weeks were quite challenging for me. First of all, because it was hard to understand people's roles and responsibilities. Also physical spaces were troubling for me. The hospital was huge, so I often got lost, literally. So in general, I had difficulties as well deciding who to engage with and what spaces to observe, because I had this feeling of missing out something important, or even not being able to make the most of my time during my field. So after several weeks, there was a specific space where I started to feel more comfortable, and this was the follow-up consultations in neonatology. So these consultations were done in order to evaluate children's neurodevelopment. Most of them were preterm children, and these consultations were always conducted by the same doctor. So I was always with the same professional. The fact that I started to feel more at ease in this specific setting made me ask myself, why was it so? And so, well, the first evident thing was the fact that this was a smaller space with fewer social actors if compared to the neonatology intensive care unit, for example, where there were a huge number of professionals, patients as well. So this space in particular was easier to observe. It was also very positive for me, the fact that I could introduce myself and briefly explain my study as well to patients and to parents before the visit. So that made me feel more relaxed. But above all, which was something very interesting, was the fact that I wasn't the only observer during these visits, because the doctor herself, she spent a long time during the meeting silently observing the children behavior without asking parents to have an active part of it. So she was observing how they behave, and for doing so, she sometimes created what we could call an experimental setting in order to observe the patient's reactions. So I guess this creation of an experimental setting, as I've called it, I guess this is something, a common practice in this kind of visits. But for me, it was quite surprising at the beginning. So I have chosen one extract as well from my field diary in order to analyze what happened in one of these moments. So, well, you can see an image of the interior of the consultation room here. So everything was quite child-friendly, as you can see. And in this case, this was the visit of a 21-month-old child who came with both of his parents. So during this visit, after asking several questions, the doctor asked parents if their child missed them when they weren't around, to which both parents replied yes. So the doctor said, okay, let's check it, say goodbye to him, both of you, and leave the room to see how he reacts. So what happened in this moment was that parents started to leave the room and waving goodbye at their child, who wasn't really paying attention to them. He was staring at a fixed spot in the ceiling. So right before completely leaving the room, the mom approached her child and placed her hand right in front of her baby's face, waving goodbye again. But he didn't show any further reaction. So after that, parents left the room, and the doctor observed the child for a couple of minutes, and then let parents back in. When the child saw that their parents were back, he smiled at them, and so the doctor confirmed that he had missed them while they were outside. But she didn't explain anything else about the whole situation or about what she had observed during those minutes. So once the family had completely left, I was alone with the doctor, and she was commenting the case with me. She was explaining me some feelings she had about it. And she expressed this idea that you can see here. She said, "Poor child, he has a stare that pierces through you." So she explained that she believed the parents confused certain things for fear of facing reality, and that she was quite confident that the kid had suffered some kind of cognitive disorder, even though she couldn't really say which one exactly. Then after observing this particular scene, I started to reflect on what the doctor was trying to observe, or what did she intend to do during this experiment, and if parents were aware about what she was trying to do. Because from my perspective, she didn't really explain why she was recreating this scene, or what she expected to see in the child's behavior. So I was also wondering why it was so important to the mother that her child looked at her while leaving the room. And most importantly, why wasn't the final diagnosis revealed to parents? So I had the feeling in general that there were different elements that were being taken for granted without explaining the reasons for doing so, or even the conclusions reached by the doctor. In this sense, well, I started to think about how what a space that seemed to be less exciting or less busy, no, if compared to the NICU, was actually an interesting setting to reflect about the complexities of the field site. In this sense, I felt identified with this idea expressed by the researcher Matej Candia, who also expressed this feeling of being overwhelmed by everything that happens while doing field work. But he also recognizes, he defends this idea of considering the field as a bounded field site, as he calls it, and that would be to acknowledge the physical and abstract limits that every field site has, as part of the analysis itself as well. So following this idea, I realized how doing field work in a hospital for the first time, in my case, could also be a strength. Because from my perspective, even if it could be very challenging at the beginning, being eager to understand a context where everything is new to the observer results also in being able to pay attention to details and not taking things for granted sometimes. So in this sense, well, this aspect made me come to terms with the fact that we as researchers won't always be able to see everything that happens or to understand everything that is going on in that specific context. But it's also important, I think, to conclude with something positive. So to recognize the fact also of how recapturing the value of not knowing certain things, as this researcher himself explains, can be also an enriching exercise while doing observations, or even a useful tool for later analysis once we have started studying our data. So, well, that's it for me. Thank you very much, and I hope you found it interesting.
Thank you so much. That was really interesting.
Thank you.
Thank you again.
Yeah. You see how.
So, do you have immediate reactions and questions? Okay, so I'll go ahead and break the ice once more. And thank you so much, Paula. And it was actually very interesting. And I was wondering if you could elaborate a little bit more on, because I kind of, you gave this picture of the clinician observing the behavior of the baby and the parents, and you observing, probably also the baby and the parents, but also the clinicians as well. So you're kind of the third, kind of the third observer. So you're observing an observer and saying, so, and I wonder, like, how were your conversation with clinicians, for instance, like asking, what did you exactly observe, or what do you want to find out, and how do you, so also like, for instance, like in my case, having been working in an emergency room, I ask nurses and doctors all the time when they were trying to diagnose or to try to understand the behavior of a certain person and trying to, in a way, kind of foresee what was going to happen within an interaction. They would have certain kind of signs, they would look at certain kind of, emotional reactions in order to unveil kind of a closeted situation, or maybe something that the patient doesn't want to say, and so on and so forth. And then I was wondering, like, which kind of conversation you had with clinicians that were observing, and to find out what exactly they were observing, and how that also changed and impacted upon your own view as a researcher. So you were also, after a while, observing the same things like clinicians, or you were still observing the clinicians doing their own observations? So how did that work?
Yeah, thank you. Thank you very much for your question. Yeah, actually, yeah, asking, well, I'm going to begin from the second question. This was very interesting because at the beginning, as I said, no, everything was new to me, so I didn't really know what was going on. But actually, then sometimes I started to observe also how children behave, or to pay attention to certain things the doctor explained to me. And even sometimes I think she was, as I guess is common in many doctor visits, she was sometimes writing on her computer or talking to parents, so that she wasn't always looking at the child. And sometimes I thought that I noticed something that could have been interesting, but she didn't really see because she was busy, it's normal, doing something else. But it is true that she gave me this explanation, as some other neonatologists as well, about the fact that it's very different what parents say about their children's behavior or about what happens at home than compared to what you see when you visit the child, actually. So I found it interesting because it's also kind of similar to anthropology, in the sense that for us, we have also this idea, right, that it's something different what people tell you that they usually do than what you observe. So I found this thing very close to us, but at the same time, it was quite challenging for me because sometimes I had the feeling that the doctor was putting under discussion everything the families told about their child. So, like, if she didn't really believe sometimes what they were explaining about the child, for fear of facing reality, as this doctor said. So I think they had, maybe not all of them, but sometimes there was this mentality about the fact that, families weren't aware maybe about the fact that there was a problem, but for their clinical perspective, that was something very clear, you see. So yeah, I was confused about it as well, but it was interesting, the fact of observing the observer. And also for the doctor, I think I don't know if it's your case, but she was, I don't think uncomfortable, but she didn't really understand what I was looking at. I think she thought I was more into patient's behavior, but I think she wasn't really conscious that I was also observing her. So after a few conversations, I also explained, but I think at the beginning, she didn't saw her role as being observed as well, see?
Thank you for that. Yeah, it's really interesting when you actually turn the lenses towards clinicians, and clinicians realize we're actually also under observation. So it's sometimes, no, it's interesting. And thank you for clarifying that. And is anyone else has questions for Paula? Okay, we'll go back there to thank you again, Paula. And
Thank you.
of course, we are going to engage with your work again in the discussion session at the end. And Ben, so next is Oiku.
Hello, can you hear me? Cool. So a little bit of technical difficulties on my side. I'm trying to share my screen. Okay. So a little bit different from the previous presentations. I'm going to talk about the challenges I had even before entering the field. So I'm Öykü İnal. I'm from Freie Universität Berlin. I recently graduated from my master's studies, and I wrote my thesis on organ donation and the inequalities in that field. And today I'm going to talk about some of the obstacles I faced through my research, and especially in terms of receiving access to the field of hospitals as an ethnographic field. The challenges I will mention might be unique to my case or unique to the location I studied in, but I believe in many parts of the world, researchers might face similar obstacles and difficulties and therefore it would be beneficial to be aware of some of these possible scenarios. So the medical field in Turkey, like the medical phenomenon, are almost always being studied by the medical professionals, and there's a very limited presence of social scientists in the field. While in Europe and in the US, medical anthropology or medical sociology are getting increasingly established disciplines, I was curious why this trend is somehow not transferring to the Turkish case. And looking back now, I can definitely say that I underestimated the obstacles that I was going to face. And I believe some of the reasons behind the low level of presence from the social scientists in the field can be lying behind those obstacles that I faced. So firstly, medical field in Turkey can be described as a very close community. The knowledge in there is often only available to those who are perceived as a part of the community already. And to be perceived as an outsider makes it particularly hard to convince the medical professionals to grant you access. One needs to describe their intentions and their research, and they should clearly prove their qualifications to the medical professionals to be perceived as worthy of this access. So through the process, I even got rejected from Facebook groups that I applied to. And like in the beginning, there's a question asking like, how are you related to the medical field? When I say medical sociologist, it was not medical enough. So I got rejected from many Facebook groups like that. And secondly, let's see. There's certain written and unwritten rules for receiving access to hospitals as ethnographic fields. And one of them is receiving a written confirmation from head of the units. And in my case, it was always the head doctors of the transplantation units in the hospitals. The other rule is making an official application to the hospital, clearly defining your research methods and waiting for approval. So both of them are written rules. They both seem pretty straightforward requirements in the beginning, some sort of formalities. But the challenges started as I start attempting to receive those. And to start with the institutional approval, the structure was very well established. There were certain forms to be filled, and the researcher was expected to fill them without any missing information. However, they were consist of multiple choice forms. They were not designed for social scientists or with the thought of possibility of social scientists might be existing in the field. When methods were asked, for example, there was simply no way of stating in-depth interviews, participant observation, non-participant observation. It was expected from researchers to submit every question that they are going to ask to all of the participants, which can be hard to deal with, especially if you're working in a field that you kind of decide the questions with a bit of reflection from the field and how the reactions you get, and you kind of modify on the go a little bit. Lastly, all the applications were just evaluated by the medical doctors. So they were the ones who were deciding if the research is worthy enough to grant access. So structure was not designed in a way that leaves room for any interdisciplinary work, which in my opinion can be understood as one of the reasons behind the lack of social scientists in the field, but it can also be considered as the consequence of lack of interdisciplinary work in this field. Another requirement that seemed, again, very straightforward in the beginning, but ended up actually leading me to change my whole roadmap, change the whole design, was receiving approval from head of the units. When I went there from hospital to hospital, unit to unit, and explained my research and asked for approval. I mainly received like excitement and interest from their side. But what was unexpected for me was I also received demands for co-authorships. To make it clear, these co-authorships were not in relation to any kind of wish of contributing to the paper of any sort, but they were, so to speak, a sort of bridge tolls to let me do my research in their unit. And it was also, unfortunately, not a very isolated case of like 1 or 2 hospitals. Through this period, I think I talked to like more than 6, 7 hospitals, and in all of them, that was the demand I received. And the more I talked to people in the field and the university, the students that are part of the universities of that hospitals, I came to notice that this is like a kind of established unspoken rule in the field. And anyone that wants to do research in that units kind of need to pay this fee in order to receive access. So I believe this is a very unique obstacle for the sociologists or anthropologists that are working in the medical field. I didn't receive such demand in any other field I studied in, or I never heard something as such from fellow sociologists that study in different communities. In my case, first of all, I wasn't willing to grant this fake authorship, and at the same time, even if I wanted to, it was a master's studies. I was supposed to write it by myself, like by rule. It's supposed to be single authored, and even when I try to like explain, like, you know, this is a master's thesis, it is simply not possible. I still couldn't convince the head of the units. So I believe I spent around 3 months with trying to find a way to receive access into the field. And I finally noticed that I need to change my roadmap completely. And to start with, I knew what I wanted to study. I knew who were the key actors in that field and with whom I needed to speak. So I started brainstorming a little bit about how to receive access to them. And I started visiting hospitals again, speaking to health professionals. But this time, instead of asking for access to the whole unit, I just asked for their individual participants into study. So I made interviews with the ones that confirmed, just one-on-one. And after the interviews, I asked them, yeah, do you have any friends or like fellow professionals in the organ donation field that might be interested in joining as you did? And as a snowball method, I start collecting names from the names and the whole chain of, I ended up having access to 9 health professionals, like organ donation coordinators, doctors, nurses, and different providers. And some of them also had close friendly relationships with the previous donors that they have. And they made a call, they said like, there is such project, would you like to be a part of it? And some of them said, yes, sure. And I got the contact number of those. Some of them didn't want that, so I never really bothered them, never received the contact number. And after each interview with the donors as well, I asked the same question. Do you have anyone that you can suggest me to go talk to? Do you have any friends having similar experiences? And how in the, like, they usually stay in hospitals in really long hours. They spend hours for waiting for the test results, waiting for the procedures, and it's not uncommon for them to have friendships or connections while waiting for this period. So most of them had access to other donors as well. So no, snowball. And by the end of it, I had recipients of like 30 people, and the research was successfully completed. It unveiled some of the inequality dynamics and the reasons behind them in organ donation field. And as a master thesis, I received highest grade as well. And what can be learned from this? For the medical field, I think it's absolutely necessary to be aware of the obstacles that are possibly discouraging social scientists to be active in that field. And there should be definitely creating room for other disciplines and alternative methods if we want to see different perspectives in the field. And the message to take as social scientists ourselves, I believe, is access to the key actors and people are not always necessarily going through the institutions. It can be more convenient sometimes, or in some studies, it might be absolutely a must. But if it is too hard, sometimes it's a good idea to take a step back, get creative, and focus on who is going to make your research possible, just the key actors. If as long as you have the access to the correct people, I think it's still going to be possible. So that's the message from my side. And thank you for your time. If you have any questions.
Thank you so much. And thank you for the very interesting also presentation, because it's something that I think everybody doing research in a hospital at some point experience, and of course certain contexts more than others. And having been doing hospital ethnography in Italy, I experienced similar problems. But at the same time, I think Italy is opening up a little bit more, and also it depends a lot on, you were also doing something that could have been very much problematic in the sense that it's organ donation. There is always the kind of potential problems and so on and so forth. But let's just open the floor for questions, and thank you again. Okay, I'll just jump right in again. And I just wanted to ask you about, all these barriers that you encountered. And I think it was very interesting you listed all the different barriers, like the structures of ethical board meetings, but also the ethical boards applications, but also the fact that you had to have content and the exchange value of publications as well. And I was wondering, like, have you thought about making an ethnography actually of the policing of the field of medicine in this sense? Because that would be actually very interesting. I myself thought about, like, sometimes to just use my attempt to actually get into the hospital as an ethnographic case in itself. Have you thought about that? Because it's an interesting case to be made, because in some way they're actually actively policing their own field of expertise. So it's not about lack of access. So it's not only about the fact that sociologists and anthropologists could be more present there and so on and so forth. But there is kind of there is something there when it comes to the actively drawing strangers out, because they are going to provide critical expertise that we don't actually want. And I was wondering if you could elaborate on that, if you thought of it.
Yeah, I mean, it's definitely an interesting thing going on in the field for me as well. To start with, this presentation is actually getting sourced by the limitations in the field part of my thesis that turns into the whole presentation. It could easily turn into a whole new research, because as I said, I also had a chance to talk to different students actually in the academic field of like medical field, doctors, nurses, and so on. And it seems like a very well established set of rules. Like there is also like the bars that you mentioned, they're like really interestingly established. They are like not spoken out, but everybody kind of knows about it. And I believe this is a really interesting project that can happen. Through this, I actually thought that, okay, the next step, I'm really going to take time in like studying this. And I also come to a point of reflection, like, okay, they kind of don't want to give me access. What happens if I actually study this and this is known? How I'm going to get access after that point for any kind of medical research in Turkey? I'm going to be like flagged. But yeah, that's definitely a good idea. I would like to explore that.
Matthew, go ahead.
Yeah, I have to agree. I immediately, when you described the idea of studying gatekeepers, the conventions of gatekeeping in hospital setting. I mean, I would read that. It sounds great. I had similar experiences, but I'll wait for my bit to share. My question is around kind of how did you do your sort of, I guess, stakeholder or gatekeeper identification as to who to talk to? Was there a process that you did, or any kind of mapping process to find who the right people to talk to were?
Did I understand correct that are you asking how did I reach out people initially, the gatekeepers?
How did you identify who the right people to talk to were? Was it purely by position in the organization, or
for my case, the most helpful ones were always organ donation coordinators, not even doctors or nurses, because the system is as such that every person in the hospital needs to go through the approval of this organ donation coordinator. So they have the information of decades of work and access to like every key person. So they knew more about who might know more. And I knew that they might know more. So basically I targeted these people and I like kind of knocked the door of them in every hospital.
So you used the process itself to recognize who would be central to that process. Yeah, that makes sense. Good job.
Thank you, Therese. And are there any other questions? Okay. Thank you again, Oiku. And so we will probably get back to your presentation and the final discussion. And so I just leave the floor to Matthew then.
I just need to wait for this presentation to close, and then I'll be able to, there we go. There we go. Is that sharing okay? Yeah, brilliant. Yeah, so I'm going to be focusing on anthropology and quality improvement in UK NHS mental health services. A little bit about me. So my name is Matthew. I'm an anthropology research student. I do that part-time, so it's a long road for me. And I've been on the program since 2020, and it's my registration is all the way until sort of 2026, 2027, which has some advantages because it gives me time. And alongside being a part-time research student, I also work as a full-time NHS quality improvement advisor, a role that I actually sought and pursued to support with this piece of research. It's quite a senior role within the health service, actually. So I'm very fortunate, and I'm in a very fortunate position to do research. So I'm very mindful of that as I present this. I've worked in NHS for about 11 years, so I'm quite familiar with the setting, and my research is in a mental health trust. So this is a large organization that consists of lots of hospitals and community services that solely focus on providing mental health care and care for people with learning disabilities or neurodevelopmental conditions. Okay. So if I just go back, actually, this is a little image from inside the hospital where I did my fieldwork, and I'm doing it currently. My fieldwork is focused on 2 adult acute inpatient wards. So these are 2 wards where adults go for acute treatment of mental health. The majority of the patients, surface users, on these wards are detained. So the level of acuity is very, very high. Some of the patients there are informal and they're of their own choice as well. So just to give you an idea of the setting we're working with. So I'll talk a little bit about my research, and I'll talk a little bit about QI, and hopefully that'll show the kind of interface between the two. So my research is called Producing Culture and Care. It's a study that involves sort of iterative phases, and kind of the three central phases is 18 months worth of sort of hospital fieldwork using participant observation with a couple of methods kind of augmented into it. The fieldwork is based at 2 adult acute wards, which I've just explained. And the research activities are completed with the service users, the patients, staff members, and other visitors such as family or carers or other people that might be connected to the unit, like advocacy services or other third sector, people working for third sector organizations that support the delivery of care. And what I'm interested in are people's experiences and the meaning of what care is. And the relationship with clinical expertise. So what skills produces high quality care experiences. There is a phase at the end of it. So these three main phases of my fieldwork that has this sort of participatory action research sort of side to it, where I blur between quality improvement and anthropology methods for the final part of my fieldwork. So just as a brief overview, kind of the first phase, feels like a long time ago now. I spent about a year, so I can really relate to the boss presentation on the struggles of overcoming the barriers to access, discussing with established researchers, my supervisors, peers as well, so other research students, but also other people working in, like I was at the time, which was education within the health service, and then stakeholders, and that involved service users, patient support groups, carers groups, and clinical groups as well. Just exploring the topic of care and expertise. And from that, I designed a literature review. I used quite a systematic process to identify ethnographic studies that connected with the areas of interest identified by those stakeholders, and did ethnographic synthesis, at least an adaptation from what's described as ethnographic synthesis, a good quality literature review to really look at persistent components really that were present in the current literature that was out there. Yeah, this kind of gave me my initial framework that I then designed the study from. Get a little snippet there. We haven't got much time. You have to cut me off if I get talking too long about any bits, because I'll just go on and on if you leave me to it. So this is just general overview of phase one, that kind of guided reading and stakeholder engagement that led to this sort of multidisciplinary literature. So it wasn't just sort of anthropological research, it was included sort of ethnographic work that was done by nurses. Some nursing literatures, some great ethnographic work there as well, medical too. And then this led towards the design and the kind of research questions, of which I probably have too many, but I couldn't help myself. The top one being the main one. Yeah, so at the heart of it really, how meanings of knowledge and practices are understood, embodied and enacted by those receiving and providing care. And the setting was selected actually because it's quite a closed setting, and many people's stories aren't heard when they're detained, due to both sensitivities around mental health, but also quite rightly in many ways, the protection of privacy for those there. So the study's been designed quite carefully to retain obviously protection of identity while still allowing people's stories to be heard. Yeah, hopefully you've had a chance to read some of them. So next phase, which is kind of what I'm doing now. I call it the sort of discovery phase of the research. And this is where I'm present. So I visit the 2 wards 5 times a week for up to 5 hours at a time, just to be present within the clinical setting, engaging in everyday activities on the wards. And really this is to identify particular social situations and do informal interviews to start to understand what care means locally. And a lot of time people say, well, what do you mean by care? And to which my response is, well, that's exactly what I'm asking. Yeah, tell me what it means to you. And beginning to unpack really moments when care occurs and how it manifests. So this is where I am at the moment. And it's been really well received by both the staff and the service users, which is really nice. And it's something that a lot of people connect with a strong connection actually between risk and care coming in quite close, and this idea of caring for someone sort of in their best interests, or caring by facilitating what's important to the person. So these two ends of the spectrum of care. And then I facilitate sort of focus groups, little workshops where I feed back kind of what I'm currently, how I'm interpreting what I'm seeing and hearing, and allowing both the patients and the staff to respond to my interpretation and correct me, really, whether I've gone off track, or have an opportunity for two-way dialogue. Kind of methods that are used, very familiar to everyone in this conference probably. So sort of field notes of descriptive and focused observations, a lot of jottings. Oh my goodness, to stay on top of them all and type them all up is really tricky. I don't know about anyone else, but yeah. And trying to capture everything, because there's so much. I loosely use sort of Spradley's framework to sort of quiz myself afterwards on my own jottings, and then refine them as I write them up into a database. I audio record focus groups and then transcribe to do sort of thematic analysis on the content. And I photograph art that people produce with me, because a big part of what I do once a week with the patients is just go in the art room and see whether or not people can better express themselves. Staff too, actually, with different mediums. And we just kind of have a bit of play with that. And I link in with the art therapists to make sure that's done safely too. So yeah, I've got a lot of access. I'm very lucky. It's kind of a contrast to the last presentation. Sorry. So next stage, which I'm not onto yet, I'm going to invite the staff and the service users to feedback areas of particular interest that's valuable, important to them. And then in those areas, I'm going to be conducting semi-structured interviews to delve a little deeper into them and do more selected observations. So for example, if the process of preparing for discharge from the hospital, if that's identified as something where people experience a true sense of being able to deliver high quality care or receive care, then I will rearrange my meetings to make sure I'm arriving to be much more closely aligned to when that occurs, to unpack those particular practices. That's the plan. But I'll let the wards decide where those will be. Again, field notes of select observations are going to take place, and then transcripts of those interviews with a range of analytic approaches at the bottom. I love mixed methods research as well. I like to know the detail, but I also like to know sort of frequency and scale and scope. So alongside doing this, I'll be able to extract kind of the metrics that the hospital gathers. So for example, durations of admissions, numbers of incidents, those sorts of data. And the idea is to maybe look at how people's attitudes and views around healthcare change over time, and see how that connects with the metrics that we're seeing at the bottom, with individual patients and staff providing consent to me to create case files so I can map their particular stories over time, of course anonymously. This leads us to the final phase, and perhaps the kind of exciting one that maybe is most interesting, this idea of feeding back for this final step. We've done the initial discovery, we've done the exploration of the areas you found most interesting. So now, what opportunities for improvement have we learned together from this exchange through anthropological research? So I'm going to be using the model for improvement that's used within quality improvement in healthcare settings, alongside mechanisms from that I don't know if it's quite young compared to maybe some other areas, but design anthropology for co-development. And so this would be my my sort of approach to analyzing in terms of unpacking the content. There's an approach called rhizomatic analysis. So the one side of it is hopefully it will produce some knowledge around care in the setting, while simultaneously providing and exploring these different lines of flight where actually we might be able to change ways of working or change practices live within the research project, and then see the impact that that has, both through observation, through what people are feeding back, but also within the metrics of the hospital as well, seeing whether or not see whether or not we're seeing a measurable change in those health metrics alongside qualitative feedback. So that's the study. A little bit about quality improvement, if I've got time. So quality improvement is a flourishing kind of component of corporate services within healthcare at the moment. And essentially, it's a systems approach for thinking about how organizations produce certain outcomes. This is a image that I've adapted from really good paper by Marshall in 2020, Going Beyond Quality Improvement Projects. And it just describes how you can understand healthcare organizations as systems that need careful tending to. So you've got this idea of quality planning, where you're identifying the needs of a particular population and how your organization will meet those needs. You need some quality controls. So what are you doing to ensure that you're meeting certain standards consistently? So for example, maybe particular control drugs need to be kept at some certain temperatures. What practices are being asked of the team to ensure that happens, and how are they maintaining them? Quality assurance, those checks, normally auditing. Again, everyone here's probably familiar with the auditing that happens in hospitals. There's lots and lots of auditing that gets done. And then improvement being when you do spot an opportunity for improvement, how do you design that change to respond to those needs? So there's a bit of a visual, and what we can do maybe with the skills from anthropology, I think, fit wonderfully into this. And I've certainly felt that it's been a massive asset. I couldn't do my job without the things that I've learned from anthropology. Is actually for quality planning is the process of brokering what these measures are. What are the measures for quality? Yeah, both quantitative or qualitative. And quality planning is setting what those are and thinking about the time frame for which we're, I guess, trying to analyze them, determine the rate. Is it monthly? Is it weekly? What is it? What are we working to? This is where quality control comes in. Once you know what those measures are, you can start to map them and understand them over time. Yeah. Quality assurance would be saying, well, actually, what's good? What do we need? And maybe quality assurance in this diagram is that it should always be below this line. And this is often in hospitals where they find themselves dancing up and down, red, green, above compliance, unsure as to whether or not to take action. Sometimes nicknamed spuddling in the NHS. Yeah, people are so frantically looking at month-to-month data points that they fail to see that the system itself is providing variation that perhaps is failing to meet their need. And the whole variation needs to be looked at rather than each point on its own. Yeah. And if you see that, it allows for this opportunity to engage with those communities at the point of where the quality issue is. So if this is falls, that involves getting carers together, physiotherapists, the patients themselves engaged in conversation around what could reduce what those are. If it's access to, say it's reducing waiting lists, yeah. How do we engage with local GP practices to understand their referrals, to why people are approaching the hospital? Why do they not attend or skip appointments? You're getting the people closest to the issue present and listening to those stories, all skills integral to anthropologists for this process of quality improvement. We're inviting people to test changes, to target these issues, to see whether or not it impacts on the measures that we agree have counted. For improvement itself, kind of the three questions that we're asking: what are we trying to accomplish? Immediately, with the anthropological lens, we can see the inherent kind of social components to all of these, can't we? Yeah. What are we trying to accomplish? It's something that needs to be agreed or brokered within a population. How we know that a change is an improvement, and what change can we make that will result in improvement? And then these cycles of testing ideas, which if you're at the heart of it, if you're doing participant observation, you can monitor these to coach the team through planning those changes, practicing them safely, studying the impact, and then acting. Do we adopt this? Do we need to adapt it a little bit more, or do we abandon it? It sounded good on paper, but actually everyone hated it when we gave it a go. And this allows us to really pick apart, the system, the variation that we're seeing, unpacking people's theories of knowledge around the issue, and ultimately thinking about human behavior and experience. I think anthropology has a huge amount to give to the field of quality improvement. And at the moment, I'm the only person that I've met who's got an anthropology background working in a QI role. So I would hopefully, at least locally within our QI networks in the UK. So I would love to sound the alarm and say, come on, where is everyone? Come and join me. I hope that was interesting and useful.
Thank you, Matthew, and thank you for sounding the alarm and having, more kind of possibilities for anthropologists out there. It's always nice to know,
Yeah.
and it's great. And thank you so much for this. I'll just open the floor for everybody having the possibility to ask questions about the presentation. Okay, I'll ask my question again. So no, I mean it's very interesting, and I was thinking about the field of, if you could actually tell more about the field of quality improvement and what are the challenges right now that, for instance, like hospital institutions face when it comes to create both like accountability and audit, and probably we are all familiar about these kind of processes, but at the same time, if you can elaborate a little bit more in what you have encountered that hospitals actually ask the social sciences to come up with because they have a problem with. So like which kind of measures, and I'm particularly thinking about, I don't know, like statistical measures trying to understand, for instance, like care reliability or the posture, something that it cannot really be measured, but they're trying to do that anyway. So that then after a while, social sciences kind of come in order to actually try to account for something that is simply not countable in some way.
Yeah, a really good point. I think you're right. I think there's this need to quantify, particularly within quality improvement. And I think it's one of its shortfalling components. The vast majority of the methods for quality improvement are taken from kind of the total quality management movement that boomed in the kind of 80s and 90s, but really kind of goes all the way back to kind of 1920s with the works of Deming and this idea of statistical process control and Schuhart charts, the idea of thinking about looking for statistically significant shifts in data that we consider to be important. What I would say is that with quality improvement, or at least within healthcare settings, these tools, there are no prizes for selecting the right chart, and the chart won't give you any of your answers. But what they can do is they can enable you to find the right place to start inquiring about a particular quality issue. So it might be that the actual quality issue itself isn't something that necessarily can be clearly measured, but we're not trying to measure to create generalizable knowledge. We're trying to create we're trying to use data for learning to create change that then may be experienced perhaps through qualitative or exploratory means. You might, for example, use the data of attendance on a particular training course. Let's say you want to improve the experience of people accessing their local GP practice. So you might monitor the numbers of compliance with a training course for the reception staff. You then look at the number of people accessing the hospital over time, the GP practice over time. You then might also look at the satisfaction ratings that they give. All of these are clues to the puzzle of what questions you should be asking the population. They're not the answer to your quality issue, but they should be guiding your decision making when you think about making changes to that practice. So what training they get, did it work? Did it not work? These sorts of things. So I would say the use of quantitative measures should be an instrument to help you detect. They shouldn't be instrument of determining, because that's just not the purpose of it. Hopefully that was that clear. Sorry, I felt like I went around and has it a little bit now.
Thank you for that. That really clarifies it a lot.
Okay.
And is anyone else wants to ask a question? Okay, so I think we can just open up the conversation and have a broader discussion. I just wanted to reply briefly to your comments, Matthew, because I was thinking about, like, oftentimes, or at least that's my experience, like working inside a hospital, happens also the other way around. So I was asked, like Oiku described, actually, I was asked to take part in some publications. And of course, the majority of publications within the medical field entail some sort of statistical analysis of sort, right? And the problem that I was interested in, so that was during my PhD, so I was having a little bit of more of leeway, and either way, it was actually quite good for me as well, to publish. So I said yes. I ended up saying yes. What I was interested in finding out is how nurses work actually is not accounted for because of the kind of accountability that exists within emergency rooms. So basically, a nurse in Italy is unlike the UK, in which you have nurse practitioners and you can actually dismiss a patient after you have treated the patient. In Italy, this is not possible. So nurses always have to have a signature from a physician in order to dismiss and discharge a patient. And because of that, what usually happens in an ER is that a triage nurse takes care of a patient, maybe solves the problem. The patient is there with a problem completely solved, which could be fixing stitches, catheter changes, some very practical things. But of course, can be very problematic if you have a problem with that for a long time. So then, the problem is completely solved. The patient is there in the waiting room waiting just for the signature of the doctor. And that can take, like, 6 to 10 hours. And of course, what happens? Everybody leave before the signature. But statistically wise, that counts as a person that has left the ward before actually being treated. And that's bad, statistically wise. So we needed to prove, like, how there is a significant discord between what actually happened and what the numbers described. And what was interesting is that using anthropology as a way to actually change the markers through which you actually look at numbers. So in a way, like the inverse process of what you're describing. So now using numbers in order to, which it's very interesting what you're describing, because you use numbers to direct your ethnographic eye in some way. Whereas I did the opposite. So I used my ethnographic eye to come up with a marker in order to make numbers making sense of what actually was happening. So it's interesting how this could be done in different ways. And yeah.
I completely agree, and I would say for me it's a continuous process as well. So it's the ethnography identifies the measures then make more questions that you bring back to qualitative research. So it's this constant process that to me has the value if you're using that to make decisions. So you're sort of alive in the research, if that makes yeah.
No, I wanted to kind of continue on this similar topic, but asking Mariana if she could also elaborate a little bit more about, like, when people ask, so you have these groups in which you talk about how to communicate bad news to patients, and at the same time, so you have this, you have been using patient experience to educate clinicians. What's the impact that you could have there? What's your understanding of how the situation has changed since you started the project and since you have this kind of safe space with clinicians in which you can actually tell them how patients feel?
Thank you, Mirko, for your answer. I don't know. I'm not sure if I can give you like a very certainly answer, because all of this is very work in progress. You know, like the project is still going on. We are like working in our results, and actually we still have like some workshops to do with the professional. Like it's not over at all. But what I can see right now is that professionals sometimes they are surprised, no, with this feedback, like I was saying, like this bridge, no, that when we say like patients sometimes can feel like this, no, when you say like the example of pregnancy loss, no, when you say that this pregnancy is not going anywhere, but it doesn't matter because it's only a 5 weeks pregnancy, like, so this is not very important. Actually, patients feel like very like feels that this is not very empathic, you know. So, and sometimes professionals are surprised, like, oh, I didn't imagine, like I can't imagine that this is so important for them. No, so I think this is the first result that we are starting to listen right now. So because I think like healthcare professionals and patients, they don't have many opportunities to talk about it. No, like I in the context of Barcelona and the public hospitals, the visits are very short, like very fast, like 10 minutes, 15 minutes. So they have to like to do everything, to talk about their issues in this time. So talk about how they feel about what they say. Like, no, this is not very real, like in very something that they can do in the everyday work. So I think it's like a different space that we can provide.
Thank you so much. And I think it's very interesting and important there. And I was wondering if also Paula could elaborate. I'm probably interested in impact that your research has as well within this, very, I bet they are kind of very protected environment in which, parents and babies can actually interact and be observed. So what's your impact in the sense that how things have changed since you have started?
I don't know if things have changed actually, because what I have noticed, I think I've been with gynecologists and neonatologists, and my feeling is that neonatologists in general, I think they are particular. I mean, compared to at least some other professionals in the reproductive medicine. So I think they are very aware of, I don't know, for example, the importance of the child's context, no, the family specific situation, if they have, I don't know, difficulties to come to the hospital or different aspects of this kind. So in this sense, it wasn't that easy for me, let's say, to identify aspects that I think should be improved. There's always things that could be improved, of course, but if compared to the gynecology consultations, in those contexts, as Mariana explained as well, you see there were a lot of things, a lot of topics from the beginning, many things that were surprising. And instead with neonatologists, I saw that they had this, I don't know, they were more sensitive, I guess, to certain aspects. So in general, I think it's always important, and I wanted also to ask to the rest of you how the specialists, the people you were working with at the hospital, how did they react to your findings? Because I think for Mariana and me, something similar is the fact of reproductive medicine. You see that there's always a topic where there are so many things that people don't talk about, or that are maybe sometimes not very discussed in the social aspect. And so for us, I think this is why sometimes doctors are surprised when we are starting to explain, the patient's point of view. So I think this is changing now, but until a few years ago, they weren't very conscious, I think, about certain topics. And I was guessing it's for the rest of you, this is the same case, or since you are in a different topic, they are more aware, I don't know, about certain aspects.
Thank you for this. And yeah, this is a great topic of discussion. And maybe I'll probably like direct this question to Oiko. I think, she has a very like sensitive field work, and she have been struggling so much when it comes to getting access. So like, how did your participant react to your results and your presence after you actually had access to them, like to the interview and so on and so forth?
I mean, difference in my study, I think, would be that my participants that are health professionals never actually got the result of the study or any kind of feedback back from me. When in fact, in my thesis, I was also like thinking about it, reflecting on it by myself, thinking like, how would be the reactions if they see my thesis? Yeah, I don't know. It's still something that I'm thinking about, to what extent I should be honest about my opinions about the participants in the medical field, and to what extent I should like kind of filter it out to the eye of them, the possibility of them seeing it. In Mariana's case, for example, I was really wondering like how these people received the feedback from the field, because there was like very direct criticism towards them, for example. And in my case as well, there was like very direct criticism to the medical researchers. But yeah, I don't know. I so far I don't know how they received it.
Just like a quickly answer. One thing that helped us is that we were in more than one hospital, and actually in the and all the network loans. So, and actually more than one city, like some hospitals are from another part of Spain. So we always say that the examples that we brought to the workshops with the professionals is not necessarily from this hospital. No, and sometimes we change like some details to anonymize it more and more. So they like, we are not in discussing exactly your attitude, it's like an example or something that happens in another hospital, but it's like an opportunity to discuss things that happen every day. So I don't know, it's like a possible idea.
Yeah, it makes more sense to me now, knowing that you had a really big pool of people that didn't necessarily make them feel like, okay, they are talking about me. In my case, I felt it even more trickier because I'm specifically talking about a profession that only existed like 15 of those people in Istanbul, and 99% of these people are women. And I tend to use code names for people to make it like smoothly telling the story. And then when there was like really questionable actions of one health professional that I wanted to mention, but at the same time, as soon as I mention a gender coded name, I'm going to be outing him, basically. So I try to use gender neutral names for basically everyone in the study, but yeah, it was tricky.
Matthew, do you want to say something? Go ahead.
Yeah, I was just thinking, I've similar concerns. It's why I use the 2 acute wards. So if there are situations like this, I can protect the people that have informed me. There's a really good book I read called What Would You Do by Bosk that's all around. He describes this idea of ethnographic betrayal and provides a really good example of, when he gives back his thesis to one of the doctors that was a really key informant, and the person was horrified when they read it, and how they then managed that. So it's quite an interesting book to read, actually. And one of the things when I discussed this with my peers at University of Kent, they were saying, well, one option done well is like this idea of composite characters, where you create these sort of fictional characters that are composed of multiple people and can be composed of different people at different times, but then make that overt at the start when you're using them. So, here is a character that embodies maybe a nursing experience, but can tell the story of multiple nurses at different times. It just again adds that layer of anonymity. I don't know if that's useful, but it's certainly something that I'm early days of my field work, but it's one of the tools that I'm prepared to use if I fear that someone's reputation or could become emotionally compromised by something I'm writing, because of course their well-being of our participants has got to be at the forefront of what we do, really. Yeah.
Yeah, no, and that's a very interesting topic, and also because there is, on one hand, the possibility to actually manage our professionals and to be recognized, because usually when you are inside a hospital or within a field of expertise which is very limited, it's, people know each other. So it's always very difficult to anonymize completely people. And at the same time, I have also been using cases that have been anonymized in order to teach them structural competency. So I have been using ethnographic cases to make them realize that what actually happens in the case is not simply based on the decision making of single individuals, but is also determined by different structure of power, which could be, from racism to structural inequality to problems when it comes to healthcare shortages and so on and so forth, which determine the outcome of the interaction. And so to make them realize that, because we are usually actually very in a habit to think through an individual encounter, I have to use practical cases and I have to be very faithful to the case. On the other hand, the problem is that how do you put a case which usually is kind of a bad case, so something very bad happens with the case, or at least, not exactly nice, anonymized, even though I have to remain very faithful to the reality of it, because otherwise the case would not make sense and the narrative would not drain people in, and they would not recognize like what happens within their own clinical work. So there is always kind of a bargain between the two, and it's so interesting how we manage to strike this bargain. And of course, there has been in ER where I have been working, and now I'm working in primary care. There are things that I don't write about, and I cannot write about. So let's put it simply, just because first the economy of the text, because if you write about everything, then you will end up probably like deranging the topic that you actually want to talk about. So there is also kind of a narrative decision making, but at the same time also because that would be probably unavoidably recognizable, and people career would be destroyed. So then you have to kind of bargain two things, and of course I'm not saying that it's that is right, because I don't think it is. But yeah, so that's the bargain that I try to make. But thank you for all the talks, and I think the interesting tension that is in there, your discussion about like access, but also the possibility to talk about certain things. It kind of draws the line between the limits of collaboration, of the possibility of collaboration. And I think both the policing of borders of knowledge, but at the same time also the fact that you cannot talk about something because in the end it will raise questions about the practice of a single person. And in that sense, social sciences probably are not so much inserted into audit structures because as Matthew were saying before, if we probably were inside audit structures more, then it will actually be our job to point the finger towards something that have happened and shouldn't happen, how it happened, and so on and so forth. So I was wondering, like, how within your work you think your work could actually help improve the quality of the service that you're studying. How do you think that could be made on the base of the knowledge that you've gathered? And this is an open question for everyone, of course.
Well, I think it's important also to have an open conversation about it, right? As Mariana explained during these encounters with these meetings, no, with professionals, but not only these spaces, but having the opportunity. I don't know. Sometimes it's not easy, I know, but to have a conversation also about how they feel, about our findings, about what we are studying, because sometimes I think they are not really aware, as I said before, about what topics we are interested in, or the fact that we are always looking at everything, right? Because I think sometimes the health professionals, they have a different approach to problems, let's say, or to situations. So I think it's very important to know how do they feel about our findings, and maybe constructing together, because I think sometimes they are also aware that there are limits they have as well during, I don't know, for example, this bad news, for example, giving bad news to a patient. So many professionals told me they have difficulties in doing so, and this is something you don't learn during your university, during all your preparation as a doctor. So, well, I guess there's always a personal part in order to face certain situations. So I think sometimes they are aware of certain aspects, but they don't have the tools, or I don't know, the institution, maybe they don't give them the possibility to explore how to face these feelings they have, or these difficulties. So I think, yeah, that would be interesting to have like the possibility to make a conversation between all the professionals, right, in order also to see what's their point of view about it. So.
I can go next, and I agree with what you said. And for me, when the question was around impact for improvement following, yeah, for me with the research that I'm doing, I like to think of it helping in one way. I want to contribute to our community of anthropologists, so being able to share the methods that I've been able to experiment with during my studies, and then listen to everyone else's experiences. I gain a lot from that. I hope it's useful to hear my attempts of experimenting with different ways of using anthropological methods. So there's that element that I hope is a benefit. And then when it comes to patient care, I think because we are working with hospitals, the potential for improvement is really high. Social science allows for a totally different way of looking at issues, and it can open a lot of conversations that go across the normal professional power struggles, perhaps between the different health professions even, and that labor market that's present. And it allows people to talk about the underlying quality issues, I guess, or experiential issues. We almost can invite change. Like, for example, you're able as a sort of insider outsider to observe the insensitivity. And actually, when it is brought to light, if people are surprised by that, then that enables a new conversation where they can then take control of that narrative and think, this isn't who we want to be, or this isn't what we want to be normal. We're aware that the system we work in perhaps has eroded, that sensitivity. So how can we create a system that brings that back and puts care back into the heart of conversations behind closed doors? And I think that would be bit that we're giving back, isn't it? Is that we bring a safe conversation to healthcare professionals where they're able to air, the reality, which of course is murky with its ups and downs, but provide people the option to change. And I would say if we can stay alongside them and walk with them and help them with it, then that's great too. But starting that conversation is key.
Yes, and like along those lines, I think the impact also doesn't mean to be helpful and not critical. So it's absolutely not a call for clinical anthropology without a critical medical anthropology or the critical side of it. Actually, as I think Oiko explained it very nicely, talking about all the challenges to getting access. So that gives us kind of at least the amount of work that needs to be done in order to actually create a space for social sciences more generally, anthropology and sociology in particular, to actually gain access and being capable to reshape knowledge forms or care and to actually count within the quality assessments and audits. So there's a long way to go, as you actually have showed. And so maybe also the question is how the impact could be a critical impact to, as you said, Matthew, to reshape a field of expertise in which people could actually have open conversation and have a critical understanding of what is to get better and what does it mean, how we can measure that, and how we can actually understand care from patients' point of view and so on and so forth as well. If you want to jump in with final comments, please go ahead. I think we have like the last 10 minutes. So like some final comments and things that comes to mind within our discussion. Okay. So then thank you again for your presentation and thank you again for a wonderful discussion. And so this is the last meeting of the Hospital in Transit, but it's not the last meeting for the Hospital Ethnography peer meeting group. So we will regather in a more kind of unstructured way. So we'll have a more informal way, which is, go around and present ourselves and briefly our work within kind of 5 minutes in order to have the possibility to have a meeting which is more kind of a conversation. And we will probably do that once every semester instead. So we'll be slowing down a little bit of pace. Thank you again for today. And so let's keep in touch. And also I will send the recording of this of this seminar through the MICE YouTube channel. So you will be able to see all the meetings of the series there.
Thank you. And will you send us as well for the next meetings? Will you send us information, or should we?
Yeah.